So, said this is a Mulligan. Mulligan system. This is the vinyl spring. What you can do is you can do a slide of the fibula. You're going posterior, a little bit lateral, okay. A little bit superior too, actually. So the fibula is on my thumb here. Okay. So I'm stabilizing the rest of the foot and ankle, and I'm doing a posterior, lateral, a little bit superior. Okay. Now they'll tell you in the course that some of their things they teach don't necessarily line up with arthrokinematics. Okay? It's just some things that they've kind of found that work, and so they just use them. Okay? And I found this one actually works pretty well quite often to reduce pain. Okay? And usually if it's going to work, they'll say it works pretty much right away. So you do the glide, I'm doing like a grade 3, and it'll reduce their pain.
And you're pushing with your thumb into like that, where the cervical of it, with your...
Fibula's sitting right here.
Okay. And then which one is the stabilizer, which one's the force that you're
I'm
putting?
stabilizing here.
Oh, and you're pulling up.
Nope, I'm pushing back.
Oh.
I'm pushing posterior, lateral,
On the fibula.
inferior on the fibula.
Lateral.
So what I'll do is I'll do the mobilization. Say you walked in with some pain, I'll do the mobilization, and then I'll have them walk to see if that helps. And it usually does. So this is something that we're going to discuss too. Dr. Brantley wanted to mention about check, recheck, test, retest.
Now just make sure it's your job to show the patient that they're getting better. They're not going to necessarily, aside from pain and maybe a little bit of range and what they can do and things like that, they'll notice, but you have to show them that they're getting better. So make sure you test, retest after you do the manual therapy. So do the goniometer measurement, do the manual therapy, then test it again, and then give them an exercise that's going to validate what you just did. So if you're trying to work on dorsiflexion, give them a gastroc stretch or some sort of self mode that they can do. But make sure that you're showing them that they're getting better, not just going off how they're feeling.
Happens quite often, and I'm always surprised. Someone will come in, I'll be like, how you doing today? And they'll say, oh, I'm not feeling good, I don't feel like I'm getting better. And I'll ask them like why they think that, and then so they'll start to discuss it. And in the means of telling me why they're not getting better, I'll say, oh, I went somewhere on the weekend and I hiked for a mile or so. I'm like, okay, well, last time you told me that you can only walk for like 5 minutes. So a lot of people don't realize they're getting better, so sometimes we have to remind them they're getting better. So it's be like, oh yeah, that's true.
That's any phase of recovery.
Yeah, I was
true.
gonna say that's
Yeah.
in acute care too, same thing.
It's hard to see the forest from the trees sometimes.
It's not just
They live in their body, right? And
Yeah.
so when we only see them once or twice a week, sometimes we can see those jumps in function or whatever better than they can, because for them it's more gradual.
It's not just range of motion, and that's kind of the low-hanging fruit, but also if you can really, what's important to the patient, so if they can't get full depth on their squat because their dorsiflexion sucks, then you have them squat, get them on the table, work on them, do the squat again, and you show them that they can squat a little bit better now.
Functional, right? Functional.
So speaking of, after your treatment, if it's working, there's a good taping technique you can use for the specific mobilization so that they can wear the tape maybe out of the clinic, right? You can take your sock off.
Yeah.
So, take the sock off and it should be fine right here. So essentially what the tape is doing is it's applying the mobilization that you did and keeping in that position, okay? So you take your tape, it has to be non-elastic, and I don't know, go about 5 or 6 inches maybe. Okay. So your first piece you're going to apply is just on the lateral malleolus, so we're just going to create kind of an anchor point. About an inch or so, make sure it's nice and stuck down there. So see how if I pull on the tape, it's going to pull on that malleolus, right? So really what you want to do though is not just pull on the tape, is you want to do the glide first. So I've got the fibula back, a little bit lateral and superior. And I'm going to take my tape. While I hold the pressure here with my left hand, I'm going to put some tension on the tape. Right? And then once I get that done, I'm going to wrap it around such that it pulls the fibula in that position. So the taping job itself is really simple, which is one of the reasons why I like it. It's easy to do. It's quick. So then what you would do is you would put your sock back on, and you say, okay, go ahead and get up and walk, and see how you feel. And you don't have any pain, but that's what you would do, right? See if it helps sustain the mobilization.
You would? So you can feel the difference on the right? Yeah.
So a little ankle spring mobilization for you. Taping.
That tape would be more for the lateral thing talking about,
Only
or in
for inversion springs.
But in response to those ligaments getting torn potentially from an inversion spring, right? That fibula wants to translate anteriorly. So it's translated posteriorly. Right?
Is there anything else you want to do mobilization wise from the ankle? We just have the toes, So any questions about that? Before we move on to the toes? Do you want me to skip the intertarsal? So the first thing that's down there though is the intertarsal joints. Right? So when you're looking at the articulation, the proximal side is always your convex side, and your distal side is your concave side. And that's true all the way down into the metatarsal and phalanges too. Proximal side is your convex, distal side is your concave. And then so of course, you would do your mobilizations as such, right? So concave and convex. Right? I think for the testing, we're going to do the So for MTP, so this would be his first metatarsal. You find your joint line. So we're going to go, so the distal end is concave, so we're going concave on convex. So for flexion, it would be a posterior glide. The distraction, if you'd like to add that. Reflection would be an anterior glide or a dorsal glide. Sorry, a polar glide. So I'm stabilizing here, right? Mobilizing. And that's true of all 5 toes.
So these would be for the NT piece?
Should be metatarsal phalange.
Okay. Was it also the same for the intertarsal and tarsal metatarsal?
Intertarsal, yes. So proximal end is concave, distal is proximal side is convex, distal is concave, so you would stabilize the proximal proximal end, and then mobilize the distal, and it would be the same direction as your movement you're trying to achieve, right?
You guys have it written as plantar glide, so that's volar.
So plantar glide. Okay.
Polar would be forearms, right?
Same thing for your
No, it's the same volar.
dips, right? Your distal interphalangeal. Also plantar, or plantar. What do you say was
Plantar.
plantar and
Plantar and dorsal, yeah, plantar dorsal.
okay? That's all right.
Just the progression, distraction with movement.
Progression, distraction with movement, common with the great toe, MCP. Yep. Remember during gait, we need some extension for toe off. Okay? How much
For
extension
running
for
into it,
toe
right?
off? Okay, so like for great toe extension, I could do a little bit of distraction. Glide. Movement, extension. Right.
So this one, don't forget the big toe, because a lot of times when people have ankle injuries, their foot flat when they, walk, you know, they're, probably rather than foot flat, they're not pushing off the toe on the full extension. So definitely address the big toe.
Okay. Any questions about that? Okay, good. Plantar dorsal glide, increase flexion extension of toes respectively. So going back to the intertarsal and tarsal metatarsal joints, so plantar glide is for plantar flexion. It's also an accessory movement for supination. Okay, don't forget that. And then dorsal glide is for pronation, increased dorsiflexion.
There's inversion, eversion, supination, pronation. Remember, it happens at two different joints, right? Where does eversion and inversion happen? Where does supination and pronation happen?
Inversion, that side too.
Correct.
And you've got all transverse tarsal joints, right, consisting of intertarsal and tarsal metatarsal, that are helping to finish off the remaining supination and pronation of that rotational isolate. Did you want to show your mobilization of movement, Dr. Fox, that we were discussing? The posterior telecoil glide with the lunge?
Yeah. All right. Go ahead and stand up. Good. So you stand next to the bed, facing that way. And you put your left foot like this. All right. So this is closed chain, right? So weight bearing, dorsiflexion. Your patient, someone like me who has real tight ankles, you want to try to increase dorsiflexion when you're weight bearing. Put them in this kind of lunged spot, and you're gonna walk at the talus here, okay? And then you can have them lunge forward to increase dorsiflexion, right? And relax. You could also assist the movement if you want, a little bit of anterior glide, distal tip fib, right? Sometimes I'll do this with a belt too. The belt would be around my waist, around their ankle, and then as they dorsiflex, you move, kind of move back like this. And then, right. I'm still blocking here, and the belt would be here. You could do it at home with a heavy band, yeah, like a self-mobilization. Mm-hmm. I think that's all I got.
Somebody can't lay down, okay? But this also helps with like the distraction with gravity.
Yeah.
Wait an hour for this to heal up in 2 seconds. So, in here you find the joint space, you go into more of a dorsiflexion, and then you can just go here. You do it one more time. Okay, it's just more of like a range, I guess. So I'm allowing gravity to do it, and then I'm pulling up, and then I'm pushing the ankle back. So I guess you want to turn this way, work on dorsiflexion. So I guess it's more just a range of motion type thing.